Well, I did get some questions from the Ask the President website that maybe I can start with one of those. And I've already answered them, and they'll be posted on InfoScope later today in case we don't get to all of them. This first question is, most of MCW's research projects are funded by the NIH. What are we doing to find new research funding support from other sources? First of all, I want to start by saying we already have the Advancing a Healthier Wisconsin Endowment, which is very unique and separates us from all the other medical schools in the country except for UW-Madison, who has the same endowment. So we do have some stability and support there that we can control. We also are looking very carefully at expanding the range of research opportunities here to include health policy, community-based participatory research, and other translational research so that we can obtain funding from other sources like AHRQ, PCORI, CDC, and any number of private foundations and corporate partners that we may not be partnering with as much as we could. We're also talking to some consultants who may help us gain access to Department of Defense and Homeland Security type of opportunities. And because of our partnerships in the bioengineering domain, we may become more eligible and more competitive for National Science Foundation funding. One other point I want to make, we have asked our science leaders to consider ways through which they can do applied research that would be directly relevant to our clinical enterprise, and we've challenged them to find ways to help our clinical enterprise improve quality and increase market share. We're not asking the whole basic science enterprise to stop doing molecular work, but a small portion of our research enterprise really ought to be devoted to this institution and making it more competitive. If we do that, then the clinical enterprise will be healthy and will continue to be able to sustain and support our research enterprise. Many people have told me that because we're focusing so much on the clinical enterprise, that we're backing off from support of research. The facts would speak against that. We have used over $40 million of our margin in each of the last 2 years to support the research enterprise. Most of that money came from the clinical enterprise. So again, I think making the clinical enterprise more competitive is the best way that we can ensure diversity of funding for the research enterprise. Wow, it's a quiet group. You weren't quiet at the beginning. The next question is, are we working with Freighter to increase the number of primary care clinics throughout the area? All of the other health systems have far more clinics than we do. Aurora certainly has far more clinics than we do, and the Wheatons do, but we have the third highest access points. It's a great question, and I think all of us in the clinical enterprise believe that in order for us to be viable moving into the future, we need more accessibility. We can either achieve that by expanding our primary care portals with Freighter, and we're already doing some of that, also with the Children's Hospital. But we're also discussing unique partnerships with the other health systems in the region that might allow us to have some access to primary care providers that would then utilize the high-end tertiary and quaternary services that we provide that can't be matched by other systems in the region. This also gets to something I worry about, which has to do with the number of primary care providers that we have in our system. We have the largest integrated specialty practice in the state and one of the largest in the Midwest, but we have relatively few primary care providers that are either employed by us or Freighter or closely affiliated with us. So we have about 200 primary care providers and over 700 specialists. A better ratio is 1-to-1. Aurora actually has achieved that ratio of 1-to-1, and they have almost as many specialists as we do. So this is something that we're going to need to work very, very hard on as we go forward. One of the problems is only 23% of the primary care providers in this market remain unaffiliated. So even if we acquired everybody else, we still wouldn't have that ratio of 1-to-1. So we're going to be looking at a number of partnerships with other healthcare organizations. We recently joined Quality Health Solutions, This is a partnership of 7 healthcare organizations in eastern and southern Wisconsin. The idea is that we can do joint contracting, but it may be that this can grow into something where we try to eliminate redundancy and duplication across the whole affiliate organization.
At one point, the medical college was trying to spin off some of our innovations and ideas into independent corporations that would then keep money back to the medical college. I don't hear any talk about that. Is it the financial climate or is it the long-term?
Okay, so the question was how committed is MCW to developing spin-off corporations with the idea that if they're successful, they could feed revenue back to the college. I'm very committed to technology transfer. I think that it's important for the college, but I don't believe that it's important to the college to generate new revenue streams. If you set that expectation, you're probably going to be disappointed. I think it's important to create an entrepreneurial environment that reaches out to the business community, encourages the best and brightest minds to come here and provides a support structure for them. Maybe 15 or 20 years down the road, if we keep plugging away at it, the enterprise will become profitable. But in general, for most academic health centers, the Tech Transfer Office requires a consistent subsidy. The reasons for that are many. It's expensive to prosecute patents. It also, there's a very, very long pipeline for drug development, and much of our work focuses on drug development. It's a 15 to 20-year process. What we're talking about doing to shorten that pipeline is to focus on diagnostics as well as on devices rather than therapeutics. So if you can shorten that pipeline, you might actually be able to generate a revenue stream. But I want to make it clear, we're expanding the staff of the Office of Technology Development. We have 1 new person this year. We're going to budget for another next year. We're partnering with other institutions. Children's Hospital is talking about adding an FTE to that pool. And we want to integrate our operations with UWM and some of the other organizations here in town. So for example, maybe we wouldn't have to hire a device expert or somebody that understands quantitative sciences. We could use the expertise from one of the other institutions, and in return we could give them expertise for life sciences. That's probably a lot more of an answer than you expected. Very good. That's what I like to hear. Okay, this is a quiet group. Will the college consider creating a new medical student pathway in rural health? I think that's a great question, especially since there is a shortage of providers in rural areas of the state, and we're talking about expanding our medical school into that area. But I have to say that the curriculum resides in the hands of the faculty, so this is an idea that we can pass along to the curriculum committee, but at the end of the day, it really is the responsibility of the faculty to decide that. I'm in favor of it, but it's up to the faculty. Okay, so Ken asked a very insightful and important question. With all the talk about expanding medical schools across the country and the 10 new medical schools that are being opened, what are we doing about graduate medical education? In other words, residency, internship, and fellowship slots. What I've done when the legislature and the Wisconsin Hospital Association have asked us to expand our medical school is to say that we'll gladly do it if we can make it work economically for us, but that it does not solve the problem. That they and insurance companies, the government, and the healthcare systems need to help us with developing new graduate medical education slots. What many of you may not know, and what I didn't know until recently, is that even with government subsidization, graduate medical education costs us money. We have got to subsidize the education and training of the residents, fellows, and interns. We can more or less break even on medical education. So I would like us to take the moral high ground and say we'll expand our medical school. We may also be willing to push hard for non-physician providers to be able to practice to the limits of their licensure and maybe even expand the scope of their practice a little bit. But at the end of the day, if we don't solve the graduate medical education bottleneck, we can't solve the problem. And we're pushing very hard for that. Did that answer your question, Ken? Okay, thank you. It wasn't exactly what he wanted to hear, though, but at least I answered it. Okay, we have another question. And by the way, if people are at remote sites would like to type a question in on WebEx, they'll be handed off to me. The next question is, Milwaukee County is planning to construct a new mental health facility on campus with smaller clinics throughout the area. Is MCW involved in these discussions? Yes, we are involved in the discussions, and we have been from the very beginning. Milwaukee County has not developed a plan to construct the new mental health facility with smaller clinics throughout the area. I need to make that clear. That was a recommendation. It has not been acted upon yet, but we do have a seat at the table, and there is some value in the idea there. Then the other question is, how will these changes impact our residency training program at the mental health complex? It'll have an impact, and because we have Dr. Lehrman at the table, hopefully it'll be a positive impact. But until a decision is made, it's pretty hard to answer the question any more specifically than that. But I want to assure everyone that we really are a major player in the behavioral health complex here, and that our advice, guidance, counsel, and participation have been actively sought by the county. Okay, so the question is, when we talk about expanding the medical school, whether we're simply talking about expanding clerkship opportunities or actually having an on-site presence that would participate in the expansion, we're talking about expanding the on-site capabilities to immerse medical students from the very beginning of their training in the community. So this is a real expansion that we're talking about. Certainly, we would like to expand rural and community-based clerkship opportunities for the students we have here. But I believe that if we're going to solve the problem of the shortage of primary care providers in communities, it makes a lot of sense to have an immersive model. So we are looking at that model. We would consider a 3-year curriculum if we can get accredited for that. The reason to consider a 3-year curriculum is that it would reduce the debt burden on the students and maybe give them more of a reason to practice in a local community. Will we have faculty there? Yes, we will. Will anyone from this campus be asked to go do something that they don't want to do? No. It may be possible that if we set up a model like the University of Northern Ontario or the Duluth campus of the University of Minnesota, there would be a completely separate admissions process and a completely separate faculty. We're going to explore the full range of opportunities. If any of our faculty are not excessively weary from the curricular innovation that we've had ongoing here for the last 3 years, we'd love the participation. I do want to mention that the Department of Family and Community Medicine has obtained a grant to look at the feasibility of a 3-year rurally based curriculum. So I'm very excited about that. But so one point I want everybody to hear loud and clear, we are not going to compel, ask, cajole, or try to convince faculty here that don't want to participate in an expansion of the medical school off campus to do it if they don't want to. Did that answer your question? Well, that's a good question. The question is, what would the staff options be? It depends on the model we adopt. So hypothetically, if the medical school was based at, say, a branch campus of UW, it may be that in the negotiations to try to keep the cost down that they provide the staff. You could say the same thing about a hospital system, but we certainly would look at models where we would have MCW employed staff. It's so early in the discussions that I can't tell you more than that. really, we've just sat down with a bunch of health systems and said there's a need, we want to help, we're willing to partner with you. We'll need money, people, and a building. I've been very clear with the people that we've talked to try to minimize the startup costs, and that we would try very hard to operate the school on tuition revenue. We can do it if we charge our tuition. We can't do it if we charge UW-Madison's tuition. It's just too low. I hope that answered every part of your question. Okay. So your question is about the basic science curriculum of the expansion, and what aspect did you want me to address? Okay, sure. Can the basic science curriculum be delivered by distance modalities? I think the answer to that is, for the most part, yes. The University of Northern Ontario already does it without a single campus. They have 5 nodes with an interactive faculty. Obviously, for disciplines like anatomy or your laboratory experiences, that would not be optimal. So we'll have to probably have a blended model that uses both distance and physical presence of basic science faculty. Again, we would not ask our faculty based here in Milwaukee to travel to or relocate to an area that they don't want to participate in. It may be that one of the models we'll consider would actually have the basic science faculty based at a branch campus of UW, and we would even use their facilities for that. So lots of questions, but we would certainly want to incorporate distance for remote sites. Did that answer your question? Thank you. And I have time for one more question, and I know everybody's busy, so I don't want to keep you here any longer than this, but I'll stand up here if anybody has questions afterwards. It says, many MCW employees were proud to participate in the recent Heart Walk and were pleased to see such a large MCW presence at the event. Will MCW launch similar campaigns in the future in support of other voluntary health organizations? Sounds like an innocent question, but there are lots of traps in it, it sounds like. Every disease that we treat is important. I certainly would encourage participation and support of any interested parties in disease-focused walks. I personally have already been asked to chair 2 other walks going into the future, and I said no. I think that when we do these things, it does distract and maybe detract a little bit from our own internal campaigns. People only have a limited capacity to give and to participate. And I had a very personal affiliation with the American Heart Association that caused me to say yes. I have a lot of heart disease in my family. A lot of my cousins and my father died from heart disease, so it's personal for me. I've also received 7 grants in my career from the American Heart Association. And most importantly for this organization is the AHA gives almost all of the money they raise here in Milwaukee directly to the Medical College of Wisconsin. So I thought that this was a fantastic organization that we should support. But I am not personally planning to lead the charge for any of the disease-focused walks, bicycle rides, or other fundraising activities going forward. So I want to thank everybody for your attention and for everything that you do for the college. We want to continue to build the team. We want open communication and a shared governance and leadership here. Thank you very much.